So our next speaker is Dr. Stephanie Jerstad. She is an associate professor of sociology in the Department of Criminology, Sociology, and Anthropology. She holds bachelor's degree and master's degrees in criminal justice and a PhD in criminology and criminal justice. Now, I got looking at the course list of things that she has taught at the university, and it became clear to me that she is another one of these scholars who possesses a wide range of knowledge and interests. She's taught sociology of the family, criminology, police and the courts, research methods, social statistics, sex crimes, and victimization, and that's not even the whole list. That's a very big course. That's a bunch of stuff. Stephanie has a particular area of interest for her research and publications, and that is obstacles to obtaining long-term and end-of-life housing for people who are on the registry. And that is the topic of her presentation today. Would you please welcome Dr. Stephanie Jerstad.
You guys are really sweet. I wish my students would greet me like that when I come into the classroom. Yeah, right? That would be good. So welcome and thank you, Narsal, for inviting me here today. I just want to preface my presentation today that I don't have all the answers. I probably really don't have any answers for you, but I do have a lot of hope. So, and I'm very passionate about this work, and you'll learn a little bit about my why and why this is so important to me and has become important to me. I will say, though, too, that I really have to use my notes today. So forgive me that I need to use my speaking notes, but I added some content at the last minute, and I want to make sure that I'm not missing out on some of these very important concepts and discussions that I want to present today. So with that being said, we'll start. I'm going to switch stuff around. All right. So some of the things that I would like for you guys to leave with today is hopefully provide you with a better understanding of how the registration intersects with the aging and end-of-life care. So we're going to discuss a little bit about legal barriers, ethical barriers, when individuals are seeking end-of-life care, and explore some policy gaps, and begin thinking about how we, as advocates, need to center both public safety and dignity in housing solutions. So a little bit about me. Dawn, already reported my education, but all of my degrees are in criminology and criminal justice. I am a professor at Millersville University. It is a state institution or a state university in Pennsylvania. It's a university, I would say it's a medium-sized university, around 10,000 students. And my dissertation was about care for the aging and the willingness of long-term care facilities to admit someone that's on the registry. So, and the reason why this became such a passion of mine, and I could talk about it all day long, every day, is back in 2016, I was a housing case manager. At the time, I was getting my master's degree. I'm a non-traditional student. And I was getting my master's degree. I worked with the Department of Veteran Affairs. I was a housing case manager for veterans who were either homeless or at imminent risk of losing their permanent nighttime shelter. And I had a lot of clients on my caseload. It just so happened that it was me that got a lot of individuals that were, forced to register or had prior sexual harm offenses. And I had a guy on my caseload named John, and that's really his name is John. I didn't just make that up, but his name is John. And he was 76 years old. He was in a homeless shelter when I met him, And we finally got him into permanent housing. And so we had this victory for him. And then not long after that, John got sick. And John needed to be admitted into the hospital. And while he was there, we were just kind of debating on, like, you know, myself and the hospital social worker, like, where does John go from here? Because it was apparent that John was not going to be able to come home. And so we realized that after his hospitalization, he really needed to go into long-term care. And John, at the time, we were living in Indiana, but John's family was in Illinois, and he really wanted to be, obviously, close to his family. So myself, another VA case manager, and a hospital social worker started calling long-term care facilities in Illinois to see if they would accept John as a resident in their facility. And we called 212 facilities in Illinois, and no one would accept him because he was a person forced to register. And I thought to myself, you know, this is, like, horrible. This is such a travesty. Like, you know, he needs medical treatment. I didn't know that people would just, you know, deny someone medical treatment and long-term care and skilled nursing care because he was someone forced to register. And unfortunately, what happened was John ended up dying before we could find him a long-term care facility that would accept him. So I was devastated for John. I was devastated for his family. And I thought to myself, you know, if I ever go and get my PhD, which wasn't on my radar at the time, I thought, this is what I'm going to study. Like, this is going to be my area of expertise, and I was going to, you know, solve this problem. And I'm still trying to solve this problem. So that is my why. My dissertation is dedicated to John. My work is dedicated to John, but not just to John, but so many other people that are just like John. My work is dedicated to them. All right, so there's many people like John. You know, we know that in the United States we have a large aging population, including those that are forced to register. And according to recent data, what we have about 700 to 800,000 people that are forced to register in the United States. And if we look at data and if we look at statistics, about 70% of Americans that are age 65 and older will require some form of long-term care in their lifetime. So 70%. So if we look at that, then we could look at the numbers of 700,000 or so on the registry, and if we look at that number, there would be approximately 83,000 at any given time that those individuals that are forced to register might need long-term care at some point in their lifetime. So, many of those individuals are facing terminal illnesses. They're disabled. They meet the requirement of long-term care, which is, not being able to perform activities of daily living, like, going to the bathroom, feeding themselves, dressing themselves. So, they qualify for activities of daily living and they qualify for skilled care. But unfortunately, like John, they are being denied access to care. So, in the literature, we talk about, in criminal justice responses to crime, we talk about collateral consequences and barriers to reentry, and we know that housing is an issue. And housing, not only traditional forms of housing in homeless shelters, but now we're adding just another additional consequence to barriers to reentry, and that is long-term care. So then I get calls and asked a lot of times, okay, so where do they go? And that's an answer that I don't really have. Remember at the beginning I said I don't have all the answers. I still don't really have all the answers. And when I'm asked those questions about where do they go, I still don't have an answer, unfortunately. And I want to be able to provide those answers. Like, I want to be able to be the one to say, well, this is where they can go. Like, everybody can just have long-term care and skilled care, and they can go here. So I get that question a lot, and I don't really have an answer for it. Their options are very limited. The majority of nursing homes reject them outright without even assessing risk. They just look at their criminal history, they pull their criminal history up, or they pull their name up on their state's registry, and they're denied access to care without even considering risk. So, there are a few exceptions. I did talk to a few long-term care facility administrators that do consider holistic approaches to applications, but that is very few and far between, and like uncovering that little nugget and that piece of sparkle in our life is very few and far between. But so the majority of nursing home administrators, they don't consider time spent offense-free in the community. Excuse me, they really have no knowledge of like the age crime curve. We know that we have a significant decline in criminal behavior as people, age and get older in life, and they really don't have this knowledge. And so, excuse me, part of what I hope that I'm doing and that others are doing are, educating our long-term care facility administrators and others that we really need to educate about what empirical evidence says instead of all the myths that they're believing, right? So, so historically, even many homeless shelters don't accept them due to legal restrictions. I know where I lived in Indiana as a homeless case manager, we had 3 homeless shelters in Evansville. We did have one shelter that would consider allowing them to stay. Excuse me. In the shelter, but we know other studies that indicate otherwise. So I think Evansville, we had a really good community around homelessness in Evansville. So I believe that was part of the reason why one of our shelters was so open and allowing them to come and stay in their shelter. So, recently I've encountered in Pennsylvania where some of families have called, or Department of Correction case managers have called, where we have individuals that are overextending their prison sentence because there is no approved housing plan. And I know that's not something that we haven't heard of or something that's new, but I did have a gentleman, Steve, he overextended or had to stay in prison in 20 months longer than his court-ordered prison sentence. He was just discharged back into the community in this August of 2025. He was able to find a long-term care facility that would accept him, but he was on that waiting list for 20 months. So, we know that that is an issue as well. So all of these, situations and these experiences really leads me to kind of hypothesize, and going back to John's story, is that, when we're not taking care of our, our people, that it's probably potentially speeding up their mortality. Like, it's just speeding up their death process because we're not taking care of them like we need to. They're not getting the skilled nursing care like they should and like everyone else is getting because of they're being denied, access to care. So a couple of things that I wanted to talk about. Part of that is like my dissertation. So when I was thinking about John, I was thinking about all kinds of things and needed to figure out where to start. Like, where do we start? So I knew that Illinois has a Illinois Nursing Home Care Act, and it was put into state legislation in 2005. And originally, as I think maybe Paul and Guy had indicated, we talked about iterations of legislation, like it goes through this iteration process. So originally, the Illinois Nursing Home Care Act was really to protect residents from employees. So that's what it was intended to do. So as the discussion kept going and furthered whatever the process is that Guy was talking about, and I know that John and all of my Parsol people know, they said, well, if we're going to be protecting residents from employees, we should probably be protecting residents from other residents. So therefore, people who are forced to register or have a prior sexual harm offense, we got to protect other residents from them too. So that's how that became a part of the Illinois Nursing Home Care Act of 2005. So because of that, I wanted to see, well, are there other states that have similar legislation to Illinois, or is just Illinois this freaky state that, doesn't allow individuals to have access to care? And what I found out was that actually there are 12 states. I guess thankfully there's only 12 states that have long-term care sex offender legislation. And so I wanted to look at, okay, so there's 12 states that have legislation, but what does that legislation say? So even though I'm not a legal scholar, I actually did do a statutory analysis of this 12 states and the language of the law, and conducted a content analysis of state statute. I wanted to see were there similarities, were there differences in the language of the law. And what I found was that it is very broad in terms of depth and breadth of state policy, as we can imagine, and there's a lot of variations. But a lot of the language of the law really mirrored that of state and federal SORNA legislation. So it was all about, prevention, guardianship, supervision, a lot of language about notification, whether it was the applicant needs to notify the facility that they're on the registry or that they have a prior offense conviction, or whether or not, if they do admit them, how do they supervise them, how do they manage them in the facility. So a lot of it was about, again, prevention of harm to other people. How do we become the guardianship? How do we supervise them? How do we manage them? But a lot of the language really mirrored that of state and federal legislation. What I did also find out that I thought was interesting is that, and I'm just anecdotally saying this, I'm just guessing, just through conversations with administrators, but they use the residency restriction as a default, as an excuse. So in Illinois, if you look at the residency restriction, it really talks about more about individuals who may have a conviction towards children in their residency restriction. So nursing home facilities and administrators, people who are making those admission decisions are just saying, oh, we're too close to a park, or we're too close to a daycare, or we're too close to, a location where children under the age of 18 or are allowed to congregate. So they don't even know what their residency restriction states. So they can just, apply this blanket ban by using residency restriction as an excuse. So we did have to do some education and some conversations with that. Now, Dawn told me that in South Carolina, there is some exclusions to that if you are residing in a nursing home, that residency restrictions don't apply, correct? Okay. So, and maybe South Carolina is unique. I don't know, I really don't know every state that has residency restriction. I really don't know what all of that says and how it applies to nursing homes. But I do know in Illinois, that is not the case. I think in Florida, Gail, you might be able to tell me, that's not the case there too. There's no exclusions to someone living in a nursing home. Yeah, that. Yeah, we know Bruce. Yes. So when I was interviewing administrators, a lot of them talked about that their hands are really tied by company policy. That, they themselves would be okay admitting someone with a who's on the registry or with a sexual harm offense conviction. Like, they were okay with that. Some of the administrators have actually had residents that are on the registry, forced to register, or with a past history, and they had no behavioral issues with those individuals. And so they would be willing and open to allow them residency in their facility, but because of their company policies, their hands were tied. I did learn that facilities that are not-for-profit are more likely to admit someone that is forced to register or with a prior offense conviction. They have the discretion, they have more latitude in discretion to make those admission decisions. They also are more likely to look at the applicant holistically. So that was a little promising, when coming up with some positive data, is that long-term care facilities that are not-for-profit are more likely to admit than to deny. I also learned that, which probably wouldn't be surprising, we could probably all hypothesize, that facility administrators who have a nursing background are more empathetic and would be more willing to make those admission exceptions than the administrators that have a business background. Those that have a business background, it's all about mitigating risk. But they're really not considering what that really looks like. They just think that mitigating risk means flat denial in bans, blanket bans. They're not considering what that really looks like. I will tell a story about an Illinois facility, a gentleman, in the majority of our nursing home, just to go back to the aging population, the majority of our nursing home population is over the age of 85. So I think, I can't even remember the statistic, it's in my research and dissertation, but the majority of our nursing home population is over the age of 85. And he had a gentleman that was in his 80s that had been married for 60 plus years. He and his wife got married when she was 17 years old, 16, 17 years old. And he was 20 at the time. And her parents were very angry that she left her home with this 20-year-old man. They eloped and got married, and then he was charged with kidnapping, criminal confinement, statutory rape. And so when the facility administrator learned of this, he was asking questions about this, and learned that this individual that is the supposed victim is actually his wife of 60 plus years. So by having those conversations, Mark was like, this guy isn't a risk to our resident population, and of course admitted him to his facility. So. I know it's not questions, it's like a yes or no question. Is that okay? I don't know. Is it okay? Yes. No. We're just repeat the questions to the end, or we're going to lose control. Okay. I didn't want to be the person that says yes or no. So, and also there's no federal guidance on how long-term care facilities should handle persons forced to register. So, yeah. But that also still is, creates fear and not knowing, and so, yeah, there is no guidance, no state, no federal guidance for long-term care admissions. And the reason why I have the Patient Bill of Rights in here is that as I was thinking about John and everyone else, and I was thinking about, how does the Patient Bill of Rights, I used to work in the medical field for many years, so I was thinking about how does the Patient Bill of Rights even insert into the discussion? Does it even matter? administrators even consider the Patient Bill of Rights, because the Patient Bill of Rights and this is just a couple of them, that as a patient you have a right to timely access to medical care. You must be treated with dignity and respect, and medical care that is free from discrimination based on age, gender, race, ethnicity, national origin, language, disease, disability, or religion. So I wanted to know, like, to me that might be a consideration. Like, if they are to follow their Patient Bill of Rights, they have to notify every resident that comes into their facility of the Patient Bill of Rights. But, you know, of course, the Patient Bill of Rights also says, like, what the patient has to do as well. And that's also not to harm any other residents, staff, visitors, etc. So I really wanted to know, like, does that even matter? Like, do they even consider that? And most of the administrators admitted that they don't even consider, like, the Patient Bill of Rights as a consideration for care. So I thought that was interesting. So the federal nursing home reform law requires nursing homes to promote and protect the rights of each resident, and emphasizes the right to dignity and self-determination. So at a minimum, nursing home residents all have a right to dignity and respect, the right to autonomy, and the right to privacy and confidentiality. So, you know, I would also argue that long-term care facilities are engaging. This is just me saying this. This isn't any, like, attorney saying this. This is just me, Stephanie, saying this. But I would also argue that long-term care facilities are engaging in discriminatory business practices, such as outright refusal of residents, these blanket bans related to criminal history rather than assessing risk. And in California, they even have a clause of, like, eviction after discovery. So if you were admitted into the facility and you've been a resident there, but then the nursing home finds out that you have a past conviction or are on the registry, they can evict you. They can discharge you without cause, without reason, without a place to go, without any kind of planning. They can evict you. So additionally, you know, in my opinion, the blanket ban on denying long-term care admissions to persons forced to register or those with a prior sexual harm offense go really above and beyond legal requirements that then raise civil rights and equal protection concerns. All right, which I really kind of talked about that just a second ago. But many, again, long-term facilities, whether it's nursing homes, assisted living, or even sometimes rehab centers, they have policies that automatically deny admission to applicants who appear on the sex offender registry without assessing risk. And so for me, these blanket bans treat, you know, persons forced to register, you know, they treat them as if they're inherently dangerous, without evidence and without any type of, you know, individualized evaluation. So in effect, these decisions are based solely on status, and those decisions are not based on conduct, behavior, or actual risk, which really aligns with the concept of disparate treatment. And if you're spent any time in the criminal justice system, that's a concept that we talk about a lot with disparate treatment. Many of those that are minorities and marginalized individuals, but I'm adding the long-term care into the conversation as well with the treatment of individuals who are forced to register with a sexual harm offense conviction. So, you know, these policies typically reject all of those individuals that are forced to register, regardless of their offense type, regardless of their severity or how long ago it occurred. It applies even if the applicant has severe medical needs, is elderly, and that they possess really no realistic risk to anyone else. One of my first conversations when I became a professor was actually in Florida, and I had a director of nursing of a rehab center call me up, and she had a patient there that was in rehabilitation recovery from a double amputation. And he was bedbound, he was a double amputee, and they were needing to find long-term care for him. He was very appropriate in his behaviors. They had no concerns, minimal risk, if any risk at all. And they called, I think, every single nursing home they said in Florida, and of course no one would take him. So she wanted my help, and we ended up calling some more nursing homes in Alabama and Georgia and South Carolina, and still no one would accept him. We did find a place for him in Pennsylvania, but then it was the problem of how does he get here? You know, who's going to pay for the transportation of him to be able to travel from Florida to Pennsylvania? So, yeah, that was a very upsetting conversation, knowing that they were continuing to have to recertify his stay in the rehabilitation center, and just so that he would have care and a place to live. Okay. So then we go on, and we're talking about discriminatory business practices, and which leads me to, you know, this ethical issues and ethical tensions. So for me, this is kind of where ethical tensions lie, is, you know, how do we uphold someone's right to die with dignity while facilities address their concerns about community safety? But this even gets more complicated when staff, other residents, visitors, other family members express discomfort. So it raises the questions over how to balance individual care with community fear. But we also know that this fear is really unfounded, right? Like, that it's unfounded, it's generated from myths and not from empirical evidence regarding sexual harm offenses. So in Ohio, for example, they can actually, in their long-term care sex offender legislation, they can actually make flyers of who is on the registry in their facility, and they can hand that out to all the residents with that person's picture, with their offense history, who would potentially be their victim, and they can hand that out. So it's really, again, you know, just further stigmatizing, further trauma to these individuals that are, you know, at the last stage of their life. Like, we should want them to die with dignity and respect, and not with feeling that, yeah, and not with feeling that, you know, they're labeled as something that they're not. So Ohio is one of those that you can actually pass around, you know, posters and flyers. So in Illinois, for example, they just have to notify staff, family, friends, residents of how to access the registry if they should so want to access the registry. So, and then other facilities have to post just a notification on their door that says someone is living in this facility with who's either on the registry or with a sexual harm offense conviction. So even though I'm a criminologist and all of my work is in criminology and criminal justice, Dr. Jill Levinson and I were talking about, like, how do we move this conversation over to a public health framing, you know, through a public health lens, because, you know, we really believe that's where it comes from. It's a public health issue, and all of this denial and these blanket bans are really criminal justice responses to crime. But how do we move that conversation in a different direction? So we needed to shift our framing of this additional collateral consequence, because that's really what it is. We're adding it to an additional consequence, collateral consequence. So this is not just a criminal justice issue or a criminal justice response to crime. It truly is a public health issue. And one definition of public health that we use when we're writing our research is what society does to assure that conditions exist in which people can be healthy. So if we look at that through that frame of thinking, we can 100% say that this is a public health issue. So housing instability at life's ends. We also know through like homeless scholarship and research that when we have housing instability, we have other higher costs, like higher emergency room use, emergency costs, money spent, even when I was talking about Steve earlier about money spent to, keep him incarcerated, that cost taxpayers dollars. So if we claim to be a system that provides hospice and palliative care for all people and long-term care for all people, then we must include those with complex histories. Like, we cannot exclude them from the conversation. We can't exclude them from, admission decisions based on their history. So Dr. Jill Levinson and I, we just completed a manuscript that'll be published later this year in Criminal Justice Policy and Review, addressing the individual's inability to access skilled nursing care from a public health frame. So we talked about there's this one concept that's coming up in public health literature. It's called, I keep messing with this microphone, quaternary prevention. And quaternary prevention is commonly described as a recognition of risks of over-intervention balanced with ethical intent to do no harm. So applying a quaternary prevention approach to sexual reoffending in long-term care facility addresses this conundrum of, preventing placement of a registrant in a long-term care facility likely deprives them of necessary care and safety to a person who really poses little to no risk of harm, and because of their infirmity, right? And because of all these other things that we know about reoffending rates in the aging population. So these restrictive healthcare policies, such as those reviewed in that study that's forthcoming, is really, it conflicts with public health philosophies. It conflicts with the Universal Declaration of Human Rights, which recognizes everyone's right to a standard of living that ensures health and well-being. So in terms of what's missing, I don't know how much time I have. Am I doing okay? Okay, thank you. Okay, good. So again, there's no mandate that ensures access to end-of-life housing for registrants. In fact, in the United States, housing isn't even a right in our U.S. Constitution. So I guess in the United States, we don't care if people have housing or not. Yeah, right, Bruce? Yes. So housing as a right isn't even part of our Constitution. We have 25 countries that explicitly state in their constitution that housing is a right, just not in the United States. So other countries have housing as a right. They explicitly they use the words that housing is a right for everyone, housing is a right for all persons, housing is a right for citizens. So it's explicitly stated in their U.S. Constitution that housing is a right. Unfortunately, we don't have that luxury in the United States. So that's missing, a policy that, of course, is missing. Interagency work, we talked about that. I think other speakers have talked about that. Like, it's so important for agencies to come together and really have some wraparound discussions about, this topic of these blanket denials and what are we going to do and where are they going to go? It's so important for interagency work to come together, whether it's corrections, health, aging services, just all of those agencies and advocates working together on housing concerns for those seeking long-term care. Oftentimes they're working in silos, and we need to do a better job of coming together and sitting at the table and having these discussions. And there's really no data about, or no tracking method that I know of who's being denied housing and why. So, I have conversations with family members, with attorneys, with Department of Corrections, with other individuals, case managers, social workers, about, individuals being denied access. But, there really is no data for me to say to policymakers or to those that are in power to say that, this is what we know, this is data, this is empirical evidence. So right now, we're kind of collecting that, I think, even in silos a little bit. I know Gail, I think Anita Killen and I have talked about, just all the phone calls that you guys get in Florida and just being able to, collect some of that data so we can start having some, hard data and hard numbers. And again, state agency policies, often exclude and ignore this population. Back in May, when John Daw and I went to our legislators on Legislation Day in May, we were meeting with Maureen Madden, one of our representatives. She's over the House of Aging, I think, Aging and something. And she didn't even know that this was an issue or a problem. Like, she had no idea that people were being denied access to skilled care because of their registry status or because of their criminal history. So she was quite surprised and felt like some of the work that we're doing could be amended in some of the bills that are currently, like, I guess, being rediscussed and reiterated, whatever Guy and them say. So hopefully we have some success with that. But, when I have conversations with policymakers or people in power, they have no idea that this is an issue. They have no idea until somebody brings it to their attention. And I'm okay with being the one that brings that to their attention. So I think the last couple of slides kind of like work into my workshop after this. So it's a kind of like a good segue, because in my workshop, I'm really going to be like trying to get you guys to think about like ways that we can push this conversation further. So, so some strategies for change is using, even though I don't know, I kind of have some differing opinions about risk-based assessments, but I would rather have some level of evaluation instead of some blanket denials. So I wanted to just preface that with, I feel some sort of way about risk-based assessments, and I don't necessarily, in the criminal justice system, like them the way that they are right now. But I want to say that because I think it's important that we do have some risk-based assessments or some sort of individualized evaluations on risk, or how long-term care facilities can mitigate risk to allow individuals access to health care. So again, collaborations with health professionals and policymakers, training long-term care facility staff on trauma-informed risk mitigation, and changes to current policies. So, there's been discussion about, petitioning off the registry, being able to, have some pathway to get off of the registry. But I will say that in terms of long-term care, it doesn't matter if you're on the registry or not. If you do have a criminal history, whether you're on the registry at that time, you still will be denied access to care. So even though I think we should have those, pathways to get off the registry, I don't know that it's necessarily a good mechanism for the situation that I'm talking about today, because it doesn't matter whether you're on the registry or not, you're likely to be denied access to care. So, all right, and then advocacy strategies, to move this work forward, as all of you know, because all of you are advocates for yourself, for others, and for your organizations, and so engaging in local decision makers, engaging in Department of Aging, given the mandate that most states require sex offender registration for life, it is highly likely that the number of those individuals forced to register are going to need long-term care, and so, this issue is just going to increase over time, and having these conversations will become more frequent rather than not as frequent. But it's a conversation that, I hear a lot about in my circle of colleagues and research and partners. So, again, building partnerships with reentry and aging and healthcare groups, and being able to counter fear-based refusals with facts about risk, aging, and reoffending. There was an article that was just published on August 18th, 2025, my late father's birthday, actually. It's with McKnight's Publishing. McKnight's Publishing is a national trade publication that focuses on long-term care and topics and concerns with long-term care. So myself, as CEO of a nursing home, and Kirsten Reed out of Nebraska, we were all interviewed for that article. And it really talks about just being denied for criminal histories. And the CEO of that, I think it's called Mission Care, and he is out of like Connecticut, Vermont, Rhode Island-ish. Is that where? Yeah. What's that? Connecticut, yes. So I think his name was David Skolschick, something like that. So he actually approached McKnight's and said, hey, we're accepting individuals that have a criminal history, or those that are forced to register, and we're not having any problems. So I'm not sure why nobody else is following, our lead. So he really was the one that kind of like pushed McKnight's to have this conversation, and I was so happy to be a part of it. So I'm hoping that in the future, he and I and Kirsten can start having some webinars with McKnight and opening those doors for discussions with other CEOs and other administrators, and hopefully they'll follow his lead in the future. Okay, so when we think about some of the takeaways, that crisis in this conversation is rooted in stigma. And, our current laws and systems weren't built to support end-of-life care. We have these criminal justice responses to crime and criminal behavior, and I'm sure they weren't thinking about, what happens when someone needs skilled care or someone needs health care at the end of their life. So, I'm hoping that with small shifts in policies, hopefully at some point big shifts in business practices, we can make a profound difference in someone's final moments, which I think is so important. Compassion and safety and dignity are not mutually exclusive. Okay, so just a final reflection. To deny access to long-term care facilities for people who are forced to register or someone with a prior conviction really creates a public health dilemma in reflecting challenges on human rights, on medical ethics, on it's a social justice issue. And so the health needs of our aging population, including people convicted of sexual harm offenses, is a reality that we truly need to confront in a fair, a humane, and an ethical way. So sometimes, these small commitments turn into big change. So before we close, I'd like each of you to think and reflect on, what is one thing that you could do in your role to move this issue forward? And just think about that. So thank you. I am Stephanie Jerstad. Here's my contact information. Millersville University, the Department of Criminology, Sociology, and Anthropology. That is my email, my personal cell phone number, and my website. So thank you all so much.
Okay. Where's the line of demarcation here? You said it wasn't just registry, it was any kind of criminal conviction.
So
White collar, I kind of missed it. I mean, what's the
yeah,
line?
so that's a good question. So in the state of Illinois, it's not just those that are forced to register or who have a sexual harm conviction. It also is for individuals who have a violent offense, whether it's domestic violence, assault, battery, but also financial crimes. Yeah. So if you have written bad checks, if you have committed fraud, now my heel got stuck again, Andy, in that thing. Anyway, so forgive me that I have one shoe on right now. Bad check writing, embezzlement, fraud, like they potentially can be denied access to a nursing home. I did have an attorney, a civil rights attorney call. I had a conversation with him last week, and that was what he was looking at. He wasn't specifically looking at sexual harm offenses or persons on the registry. He had contact with other people that had other offenses that were being denied access to care. So I'm not sure, where we draw the line. I'm gonna try to fix my shoe. Just a second, Ann. Three holes in the tape with these heels. Ann.
First of all, let me just say how impressed I am that you stood in those heels this whole time. Those are high heels. Holy mackerel, good job.
Thank you.
My question was, are there instances, has anybody made a list? Are there instances of times when someone in a nursing home caused sexual harm from the nursing home?
That's a good question.
Has that ever happened?
So let me tell you. So in my dissertation, I cited a 2016 CNN news article, and that's what they were examining. They were asking nursing homes in 5 different states if any of the sexual misconduct that was occurring in nursing homes were by someone who was either forced to register or had a sexual harm offense, and the answer was 0.
The answer was 0. Of course, the answer is 0.
Yes, the answer is 0. And let me also tell you that in Illinois, I don't know about other states, but in Illinois, when you report sexual misconduct or any kind of, mistreatment in a nursing home to the Department of Health, they do not ask the question of, does this person who, if it was substantiated, is this person on the registry or has a sexual harm conviction? They don't collect that data. But at the same time, I would have to say probably not, because they're not admitting them. So they're not even, living in their residences. So the likelihood of them being the ones that are, acting out would be 0. The other thing too, in a 2005 GAO study, Government Accountability Office did a study in 2005. They looked at 5 different states, looking at how many people who were on the registry were living in long-term care facilities, but they also interviewed long-term care facility administrators. And long-term care facility administrators reported that they're more concerned with people who have cognitive decline and no criminal history than someone who is not cognitively impaired and has a criminal history. Because we know through the disease process that people who are diagnosed with dementia, Alzheimer's, are hyposexual, and because of their disease process, they're likely to act out, and that they were more concerned about those individuals and providing an individualized safety plan for those individuals than somebody that isn't cognitively impaired and has a criminal history.
I was gonna say is we know we have a lot of people who make make movies. Someone should make a documentary about this.
Yeah, it's
Because telling this with personal stories, showing the story of a John or someone,
Steve
and then
or whoever.
showing the fact that there's not a single case they can think of where someone on the registry caused harm from their nursing home. We should put that out to the universe.
So I'm excited that you said that, actually, because I think I told Sean and Paul about this maybe last year-ish or so. So when I was at a conference, speaking at a conference last September in Ohio for Connecting for Justice, there was a producer, filmmaker person there who he won what's the award for the movies? An Oscar thingy? Yeah, okay, I always forget, like Oscar, Grammy, Emmy, I don't even know. But anyway, he won one of those for his documentary on prison hospice with HBO, and it was on HBO. So I talked to him about he and I collaborating together on creating a documentary about this subject, and he's very interested and hopes to, once he finishes his work that he's working on right now, that he can focus on telling this story. So yes. So fingers crossed, Ann, that at some point we can make that happen. Guy.
Yeah, Dr. Jerstad, I just wanted to say first, I was really moved by your personal story, your why, and I just wanted to say I believe that you are certainly honoring John's memory.
Thank you.
And the question that I had, it occurred to me in thinking about how to move the needle on this particular issue. If you've had any interfacing or interaction with lobbying or advocacy groups that are more concerned with elder issues more generally, such as AARP or perhaps medical lobbying groups like nursing groups or anything like that, and if so, where they are on this issue, and if you can speak to that at all.
That's a very good question, and I like it, and I think you should stay for our workshop so that we can have those conversations about moving this discussion forward, because no, I have not, but I think that's a conversation that definitely needs to be made, and I like it. I did hear from some other individuals from that article with McKnight's publication, so we're actually having conversations next week with a couple of different people that hopefully will continue to keep pushing this conversation forward. So I figured that might happen once that got published in a national trade magazine, that there would be a lot of contact and a lot of, stirring of conversations. So, Sunny.
Thank you so much, Stephanie.
You're welcome.
For talk. I have a couple of ideas, and that could be an idea or a question. One is, do you know if anyone has tried to sue for this kind of discrimination? And thinking about, as a category of person that is discriminated against, using that frame. And then the other thought is, so my main frame of reference is the trans movement. And I know that one strategy that movement used that was useful, because it's such a small population and it was not very resourced. So as soon as they started partnering with larger organizations that had more resources and like gay and lesbian organizations, then that's when those gains started happening legally. So that's just another, I guess, question and comment.
Yeah, good. Thank you. I think, is Mark Weinberg in here? Where did he go? He wasn't in here. I don't know if Mark Weinberg and Adele, yeah, if they've worked on any, like if they have sued anybody, because I know they do some of that work in Illinois. So, Guy, do you know? Is Paul Doubling here? I don't know if he knows. I don't know that question, but we have talked about it, like with Parsol, for sure, about having. I don't know if a class action suit is the right term because I'm not a legal scholar, but in terms of discriminatory business practices, we've had that, discussions. It just hasn't been in like, in a formal setting or, yeah. So, but we, of course, we have conversations with all kinds of organizations about this issue, and it surely has helped. It has helped me reach to a lot more people, like with Sean and her organization, with UV4 SOR, and Ann and War and Danelle and Florida Action Committee and Narsal being on their podcasts. Like, I have been able to reach people that I would have never been able to reach before had these organizations not included me in their discussions. So I thank them for that in trying to at least, raise awareness for sure. Thank you.
Thank you.
Amber. I forgot to say, and Amber.
Thank you so much for your presentation. I always learn something new every time I hear you speak. And so you spoke a little bit about this idea of risk assessment, and that is one thing that people have been thinking about. And I just want to share something from the state of Connecticut, because we also talked about, has it ever happened that somebody who was on the registry committed sexual harm in a nursing home? And the answer to that is yes. So unfortunately, we want to make sure that we're using factual information, because in the state of Connecticut, we did have a very outlier situation where Massachusetts rejected someone because they have laws that
They do.
preclude people. They sent this individual who was already very destabilized for a number of different reasons that probably had nothing to do with, his offense. And unfortunately, this person attacked a caregiver, not another resident, in the nursing home. And this gave rise to a big sort of uprising and legislation being introduced and all of that. And we worked very closely with people who were in the medical field and One Standard of Justice and people with lived experience and all of these people to really rise up and say, no, we don't want this. And what we heard from the medical community was that this makes our job harder. We heard from social workers, we heard from all of those people. So those allies understand that people are being denied care, and it makes their jobs harder. So my question to you, sorry, I didn't mean to go off on a
No, that's good.
diatribe, just wanted to share that information, is when you think about this idea of an individualized assessment, in order to be admitted to any sort of congregate living situation like assisted living or a nursing home, there has to be a nurse to assess somebody anyway, right? And so I think do you think that the education that you're sort of talking about would be key in giving people information to understand why an assessment of a criminal background is irrelevant to sort of that health assessment?
Yeah, no, I think that's a good question. And, I know that when they're making those assessments prior to admission, they're really looking, like you said, just at their health, like, their activities of daily living. What can they perform? What can they not perform? And diagnoses, and, what's their risk their safety, and so I really think that needs to be looked at as a priority versus assessing them for risk in a criminal situation, if that makes sense.
Yes, and so I think my question to you is, how do we help your work in order to get that into the hands? So I used to work for an assisted living,
Okay.
and I was regularly asked to check for the sex offense registry, which I refused to do, and then they just assigned it to somebody else and made somebody else do it. But in that context, providing that training, people really don't want to be, most healthcare providers do not want to be doing this because they recognize that people need care.
Yeah. And I'm not really sure how to, in terms of education, when I think of it, I just think of educating them on, what data tells us, and, that there is little to no risk. And so I think, reinforcing that is important in the conversation too. And you're right, because the facility administrators in Illinois talked about how the Illinois Nursing Home Care Act, actually made their job harder and took away their discretion. They had discretion prior to 2005, but because of the, Nursing Home Care Act or some of these legislations that are, in 12 states, is that it actually does make their job harder, and that they want everybody to have access to care. So I think just, educating them on, the criminal risk versus in moving the health risk forward as the priority and not the criminal risk as a priority, if that makes sense.
Thank you so much, and also thank you for honoring John.
You're welcome. You're welcome. Hello.
Hey, from my experience, I used to work in hospital leadership. I was in case management. I've placed a number of difficult patients, and I did come across a patient that was on the registry. In my experience, there were different lenses. Of course, a lot of facilities classified being on the registry with other violent crimes like murder. And so, of course, that was an automatic no. Occasionally, I would run across facilities that were concerned about having the registrant's address being listed as that facility, and what kind of negative publicity that their facility would receive based off that. And then, of course, unfortunately, they were concerned about their other residents that were, cash paying residents, paying out of pocket, whether they would lose that business. And so there's just a lot of different lenses. Are you going to address that in your research, or?
So I did address some of that in my dissertation. I just didn't talk about it today, but thanks for bringing that up. Like, some of the qualitative data that came out of that is exactly what you're talking about. And some of the facility administrators, that was definitely a concern for them, is, what if they admit someone that's on the registry or has a prior sexual offense conviction, what does that do to their reputation and their, character standing in the community? And are they going to lose, residents, or those paying residents, or residents in general? So that was something that they really highly considered when they made their business decisions to have these blanket ban admission decisions. So, that was, something that came up in conversation, a lot. So, in further research too, is taking those conversations, a little bit further and stretching out the conversations more, but also being able to talk to direct care workers and not just administrators too, like being able to talk to those people that are on the ground, feet on the ground, doing the ones that are doing the care and not the ones that are making the decisions, getting their point of view about, patients and their attitudes and perceptions is really what I want to look at.
I appreciate you addressing, the rehabilitation part, because we did have a gentleman who ended up staying in our hospital over 300 days when they were
Wow.
ready to discharge within 2 weeks
Mhm.
because we could not find a facility that would do that intense rehab that they needed. So the hospital, of course, tried to do our best as far as doing the rehabilitation, but it's not going to be the same as going to acute rehab
Right.
or a facility like that.
Right, right. Yeah, for sure. To my knowledge anyway, and at least in, Evansville where I lived and where John was, there's no question. They don't ask their criminal history. Like they don't check the registry when they have people coming into their hospital, so we have some level of health care that's provided to them. But like you said, then you had someone that had to stay 300 days because of, the inability to find, care for him at the level that they needed, which is really sad. Yeah, thank you. 3 minutes.
All right. Well, a quick comment and then a quick question. The comment is my worry with risk assessments and other kinds of tiers and everything else, although we all have to experience them and we're not always in control of that narrative, is that while it is true that it probably helps more people, it also creates a smaller class of people who can organize in the future. So for instance, if I have 50 people who are opposed to the registry now and the risk assessment lets 25 of them off, that means there's less people in the class of people that, some of those people will still organize and work against the registry, but it cuts the people who are supporting things down to a lower number, which makes it even harder to move anything forward to help the people who are left behind by any assessment. And so that does worry me when we start talking about that being a solution. And then the question is, in being involved in criminal justice discourse around the country, and especially on registry discourse, it does seem to me that there is a problem that even when people agree with us that we're on the right side of the data, that the human rights issues, that it's even counterproductive, they still support the laws because there is a part of them that enjoy, I think I've called this surplus enjoyment another time, the idea of people being punished, even if it's counterproductive to them. And I don't even think it's irrational. I think it's in line with kind of tough on crime thinking in the larger criminal. Have you all thought about kind of that problem with confronting or creating change and moving the needle?
In terms of punitiveness?
Well, just that people may not even care that it's not good or fair. They think that they just have a feeling that they should do me.
Yeah, for sure. I think that's a good question, a good comment, and definitely something to consider as we move this conversation along, for sure. And when I teach my students, sometimes they have those same feelings and same reactions of needing to be punitive, and that we need to punish these people, need to be punished severely. And but then through education, they soften a little and have different points of view. Not that we certainly know that not everybody does. So, but no, I think that's good. I think that's good comment. Hello, last question.
I was curious.
Oh yes, your yes or no question.
So simple. I was just curious if, I guess you were looking up Illinois. I'm from Illinois. If the act that was passed in 2005, if it includes specialized mental health rehab facilities and skilled nursing facilities, or just like 8 facilities for aging adults? Because I work in Smurfs.
So it specifically is for skilled care.
So it's for, so it does not include Smurfs.
No.
That's so helpful. Thank you.
And it does not include like those independent homes for the developmentally disabled and intellectual. Yeah, it does not include that. Yes, you're welcome. I will say the long-term, and this is the last thing I'll say, but the long-term care sex offender legislation that passed in those 12 states were passed between the years of 2005 and 2010. So, which was kind of the height of, 1995 to 2005, 2010, some of those amendments and, legislations that were passed. So I don't know, do we celebrate that it hasn't happened since 2010 and maybe it won't ever, happen again? I don't really know. But I will say that, you know, those 12 states were 2005 to 2010, and and then finding, you know, pockets in Florida. You know, Florida doesn't have a state sex offender legislation law, but they do have definite pockets in municipalities with ordinances and senior safety zones that, you know, you can't even be standing close to a nursing home. So anyway, thank you all. Thank you.